Good morning, members, and to the viewing public. Um, I call this Ways and Means hearing to order. Uh, Here before us is CHCC. And before we move on with our agenda, can I get a motion to adopt today's agenda? There has been a motion, has been second. All those in favor say aye. All those opposed say nay. Ayes have it. I believe we have pursuant to the OGA, the agenda has been passed out. Is there anyone in the gallery that would like to make a public comment with regards to CHCC's budget request? Being there's none, Sarge, can you um, have the members? Good morning, CEO, and if you have any members or your management team to be present, please have them step forward. Thank you, CEO, for making yourself present today at this budget hearing request. I will now offer the floor back to you to introduce your team member and for your opening statement or remarks. Thank you.
Good morning, and good morning to everyone, Chair and members of this honorable committee. So I am Esther El Muña. I'm the Chief Executive Officer and the Territorial Health Official for the CNMI. And I have with me the members of the leadership of the CHEC. And we're here to answer questions as well as also present to you our budget requests for FY 2024. We appreciate the opportunity today, and you know, there's a lot of concerns, of course, with health funding, and we wanted to show you all of that today. So. On February 16, we had the honor of some of you that met with us in the meet and greet session, and we appreciated the deep dialogue on the issues facing the health system in CNMI. There's much to be concerned about. Health has been prioritized over the years, especially on the lack of local matching funds for providing services to Medicaid patients at the hospital. Today's presentation will cover the CHC's history and financing trends, show you the CHCC revenues and CHC costs, and explain where we need help, covering the financing gaps. While the graphs and reports seem new, I assure you that they're part of previous testimonies over the years given by the CHEC leadership at every budget hearing. We need to address the gaps in funding from being a safety net provider that would treat anyone and everyone despite the one's inability to pay. We also want you to be aware of the Medicaid funding situation in the CNMI and how that will affect the delivery of health services overall in the CNMI and beyond. The effects of the Medicaid shortfall are already affecting the CHEC and private providers. From June 2023 to September 2023, Medicaid will pay the hospital for CHIP and COFA funding, COFA eligible services, but not services provided to the general Medicaid population, leaving a monthly shortfall of about $3 million. As you consider the budget of the CHEC, please see how the CHEC leadership has made tremendous strides in adding more services to the community and addressing the community health needs. We hope to provide more. We have made investments when we can and when the return on investment is achievable and faster. The Medicaid shortfall will leave the hospital in making tougher decisions for the rest of FY23. And over the past several years, again, budgets have been insufficient, and we hope FY 2024 will be different and adequate from now on. I will now turn to Caitlin Nices Mocano, who will do the presentation, as well as our CFO, Berlita Santos.
Thank you, CEO. My name is, as she said, Caitlin Nices Mocano. I'm the Chief Strategy Officer for the CHCC. And I apologize if I sound out of breath. I just have a tiny human pressing on my lungs, so I'm okay. So we wanted to go over, has the CHCC accomplished its purpose, right? It's been a little over 10 years since this kind of experiment has been going, right, with this public corporation, Department of Public Health becoming a public corporation. So we want to talk about that. We'll also talk about our revenues, our payer mix, what the certified public expenditure means. It's really important to understanding Medicaid financing for the CNMI and for the CHCC. And also our presumptive eligibility and charity care rates. We'll also be going over some of our hot topic costs, which I know the chairman, said we're not going to talk too much about medical referral, but we wanted to go over the program history and then the cost performance a little bit under the CHCC. And I apologize. We can talk about utilities if we want to, but we can skip that for time. And then our budget asks, charity care, medical referral, and the Medicaid local share. So to go over our origin, the CNMI was in a tough financial spot at around 2010, and I think we all remember that if we were here. The government had very difficult time funding the Department of Public Health. So the idea was to make the Department of Public Health independent, revenue generating, and therefore less of a burden on public funds. So this was done around 2010, 2011. And then with the funding shortfalls that came along with that, going from around $40 million appropriated from the local government to $5 million created some challenges at the hospital. And CMS stepped in and said, this is not safe. And so they issued immediate jeopardy in 2012. This was also the year that the CPE methodology for Medicaid was approved. So there were lots of things happening around 2012, and then 2013, DOI stepped in to help the CHCC turn around and address these immediate jeopardy findings. And then from there, the story is that our CMS surveys have continually improved, and then our revenues and our costs and our growth will show that story as well. And I just wanted to point out also that when the CHCC was created, there was an acknowledgement specifically from this body, from the House, that it didn't mean that the CHCC would no longer need public funds, that appropriations would still be needed until the CNMI enacts comprehensive healthcare financing, such as universal mandatory minimum health coverage. So right now we are still looking at about a 30% uninsured rate. It's difficult to tell with Medicaid PE ending, but it's still a very high rate of people who cannot afford to pay for healthcare. With that, I'll hand it over to the CFO.
We just celebrated our 10th year anniversary in 2022. So what have we done in those 10 years? We have grown our employee base from 585 to 874, locally funded, from administrative to medical professionals. Our expenditure increased from 40 million to 85 million, and so did our revenue. In 2011, revenue was just 18.4 million, but in 2021, revenue was at 83.2 million. So that's a significant improvement towards the mandate of the public law that created CHCC. So to give more perspective to how that, why that is our pride, is because prior to the creation of CHCC in October 2011, the expenditure over revenue, over hospital revenue, were averaging from 30 millions up. And those were all funded by local general fund. So for this deficit, all this deficit were funded by local general fund until we were created in October 1, 2011. And since then, the deficit have decreased because we were able to fulfill our mandate to make revenue. However, the revenue is not enough because there's still that deficit, right? We were only not in deficit when the FMAP is at 100% in 2019. The next slide shows how our deficit and how the unfunded Medicaid local match correlates, right? So if we were given the local match, there would be years where we make revenue. But yeah, so that would cover all of the deficit. Providing local match is very essential for the hospital, as shown earlier in the earlier slides, where we were not in deficit when the FMAP was 100%. But unfortunately, the FMAP is within our local control. The FMAP is a federal mandate. What we are requesting from the government is to give us the local match according to the CNMI Medicaid state plan.
So we wanted to also show you what value is being generated for the money, and to make some comparisons when the data is available, to the historical trend, and over time. So we have some data here on our dental clinic visits. You can see the trend is largely going up. And then our outpatient clinics on Saipan, there's been trends since from last year to this year, of moderate increases. And then since 2017, though, the FCC volumes have increased by 340%. So we're seeing that many more patients. Children's clinic have increased by 226%. Women's clinic has increased by 154%. So the value that's being generated is significant for those dollars spent. And we estimate that about each day, our clinics on Saipan see about 218 patients, different patients that come in our doors. Our average monthly dialysis numbers, about 2,000 treatments for hemodialysis every month, and about 450 peritoneal dialysis treatments. Peritoneal is measured in days. Peritoneal is a type of dialysis that doesn't require the patient to go into the clinic to get dialyzed. They can do home treatment. So it's a lot more convenient for a lot of patients, and not everyone's eligible for PD. But that's an important service that we've also been expanding to Tinian and Rhoda as well. On average, our monthly oncology encounters are still quite high, even though they've dropped slightly since 2022. Since we opened the oncology center in 2022, off-island referrals for oncology have reduced by over 70%. That's a significant value added. Our radiology procedures are also on the rise from last year to this year. And then comparing, longer term trends since 2017, our radiology procedures have doubled. So we're doing twice as much radiology as we have been doing since in the last 6 years. The same thing with the outpatient pharmacy. On average, our outpatient pharmacy fills over 300 prescriptions every day. This is 6 times higher than our first year of operating in 2018. So our volumes are on the rise as well. On average, our monthly lab tests have also significantly increased. The CHCC's labs on Saipan and Rhoda are the only CLIA certified laboratories in the CNMI. This means these laboratories can conduct moderate to high complexity tests. And thus far in 2023, those moderate to high complexity tests make up 3 out of 4 of all the lab tests run at our labs. And in terms of quality, our average length of stay in 2023 is 4 days. The US national rate in 2019, which is the most recent one available, was 5.4 days. Apologies. The average length of stay is used as an indicator of efficiency. This means how fast can we get patients safely discharged from the hospital as a means of being efficient with care. And then on the other side of that, we want to make sure that the patients don't come back for the same or a similar condition. So we look at our readmission rate. In 2022, the CHCC's readmission rate was 8.4%, and the national average was 15%. So this shows that we are not only efficient, but also safely discharging and giving patients the information and the support they need to stay out of the hospital. When we look at our revenues, our biggest payer by far is Medicaid, with about 60% of, sorry, the numbers didn't show up here. About 60% of our revenues come from Medicaid. Medicaid is our lifeblood. Private payers is about 20%. Self-pay, we don't get paid very much, 1%. And Medicare is also about 20%. And the bulk of the private payers comes from Aetna. It's about 70% of those private payer payments come from Aetna. And when we talk about Medicaid financing, it's really important to acknowledge the expiration of presumptive eligibility last month. As of April, there was an estimate that about 26,000 CNMI residents were enrolled through Medicaid PE. And so when this expired, their eligibility for Medicaid was put at risk. Some would not be found eligible again. Some might be, but we don't fully know what that impact will be for us. But we anticipate that our uncompensated care will go back to pre-pandemic levels of roughly $15 to $20 million of care that we provide to patients who can't afford it. So you can see there's a direct correlation between our revenues and our uncompensated care going down, and that is because of presumptive eligibility. And just to brief you on Medicaid financing, it's something that we talk about a lot, and just to make sure that this body understands, and when you're talking to Medicaid as well, so that you understand. There's 4 key components. There's the federal medical assistance percentage. This is the FMAP. Right now, we're at about 83%. There's the local government funding, which is the local share of the government puts in toward the reimbursements. There's also program operations funding. But what I'm looking at here in these figures of $3.9 million per year to Medicaid is for Medicaid reimbursements. And then there's the federal cap, which is the Section 1108 allotment. And this is a cap that the CNMI government cannot exceed of federal funding. Anything in excess needs to come from the CNMI local budget. And then there's the certified public expenditure. And since 2012, when the CHCC was having a really challenging time, paying doctors and complying with CMS, the certified public expenditure allows the CHCC's expenses to be counted toward the local match in order to receive the federal share. So the Affordable Care Act, for example, allotted $100 million to CNMI's Medicaid program that could be spent over the course of, I think, about 10 years. Had it not been for the CPE arrangement, we would not have been able to draw down those federal funds because we wouldn't have had the local match. But the CHCC's costs count toward the local match. So there's been funding, congressional funding in excess of the cap. So you can see the cap is in the dark blue at the bottom. That's the statutory cap. And then the light blue is the congressional action that's been taking place regularly, almost annually, to make sure that the CNMI's Medicaid program in other territories are fully funded or adequately funded. So you can see if we were still subject to the statutory cap, we would be in a lot of trouble. Our healthcare system, the CHCC, would be in a lot of trouble. And the FMAP, as of last year, is permanently at 83%. For a long time, it was statutorily set at 55%, which was very hard for us to meet. So in FY 2023, according to the budget law, only about $380,000 was appropriated from local funds for the Medicaid reimbursements. So if you've done just a brief calculation in your head, 83% of 64 million or 17% of the local share, where is that money coming from, right? It's more than $380,000. That money is coming from the CHCC's expenditures. So since 2012, the CHCC has borne additional costs of $91 million in the local share. So that means that of hospital expenses, the CHCC's costs are counted toward the local share. However, it is not reimbursed. So this is how the CNMI government has been able to draw down federal funds for Medicaid because the CHCC puts up the local share. And you'll see in times like in FY 2019 and those sort of times, that's when the FMAP increased. So that's when the CHCC was actually paid, significantly more. And so the local share not received was reduced. And just to go briefly over the medical referral program history, we have a long paper about it, but it's a very interesting history. And it goes back into the 1960s. 1968 was the first on record that this program existed. It was run by the Trust Territory government. And even in the late 1970s, there was a fee schedule implemented because financing of this program has never been simple. It's never been easy for the Trust Territory government and then for the CNMI government. So fraught with problems, fraught with financing problems. This program has been. So this issue that we're facing now is not new. In 2021, the Attorney General found that there was no authority for the program to be located within the governor's office. So that's when the legislature passed Public Law 2233. That was the first statutory establishment of the medical referral responsibilities. Before that, even though the medical referral program has existed for as long as the Commonwealth has existed, it's never been statutorily established until now. So talking about a little bit about the financing issues. The financing issues of the medical referral program are not new. They just were not readily visible to the legislature. That is because just for example, 2017, 2018, 2019, the dark blue is at the bottom is what this body appropriated to medical referral through public law appropriations. The red is what was actually spent in excess of that appropriation. So you can see that the expenditures of the program have been more than what has been appropriated for, it goes on more than just 3 years. But the average deficit for medical referral was about $11.4 million every year for these, at least for these 3 years. And there was a deficit for at least the last decade. So the CHCC's budget request for FY 2024 is about 60% less than what was actually spent on the program in 2019. So even though the budget request may seem very large, it's not what this body is used to seeing, it is actually reflective of the costs, and it is lower because of cost savings that the CHCC has been able to produce. And some of the investments that the CHCC has started even before taking over medical referral, just talking about some of these specialty areas of ortho, ENT, and oncology, has significantly reduced between 2018 and 2022. So in 2018, we had about 375 referrals off island for cancer care. In 2022, it's 88. There's still some radiation treatments and other surgeries that need to be done that we still can't do here. For ENT, in 2018, it was 116 patients going off island for ENT services. In 2022, it was 9. And in 2018, for orthopedic services, it was 164. And now, as of last year, it was 45. And that is all for me. Thank you.
Thank you. And before I open up to the question, is that the final? Before I open up to the members, and I apologize, I forgot to introduce my members. I got so excited. So I apologize. Before I am Rep. Yumo, Chairman for the Ways and Means, and to my left I have the Vice Chair, Rep. Plus Atal. To my right I have Vice Speaker and Member Joe Camacho, and down on the floor we have our Chairwoman for Commerce and Tourism, Rep. Julie Ogo, along with our SNIO Chairman. Next to her is Rep. John Paul Sablan, and next to him is Chairman for Natural Resources, Rep. Angelo Camacho. I believe Rep. Manny Castro is in the building. He is our Chair for Education, as well as Rep. Roman Beneventi, Vice Chair for SNIO, Next to him would be our JGO chairwoman, Representative Marissa Flores, and also vice chair for health and welfare. Next to her is the chairman for health and welfare, who's Representative Malcolm Omar, along with our rep from precinct 6, I believe, our leader, Rep. Patrick San Nicolas. Any issues in Tinian? No, none. Next to him would be our chairman for FFA, Rep. Vicente Castro, along with our fiscal analyst, TG, and our council, John, along with our IT. Our legislative assistant is present, viewing online right now. And with that, I just have one question that needs to be clarified before I open up the uh, the floor. Um, uh, with all the appropriations from the past, mostly sniled, I believe we've been appropriating to CHCC as those funds were ever transmitted to CHCC.
Um, we could speak about average. At an average, including ARPA, we received about 60% of what was appropriated to us.
Just local, like when the delegation appropriates fund, are those funds transferred to the
Not,
CHCC?
not all of them, sir. The most recent 1 million now, only 500,000 was transferred to us. And for the prior years too, I could provide the summary of the appropriations. However, I only started tracking appropriations in 2017.
Yeah, can you because we're as you know, we've been getting issues not only with CHCC but other departments that were not able to use, especially SNOUT, and our chairman is here to verify those. SNOUT funding that we appropriate to each, for example, CACC or DPW or PSS, those funds were never transferred. So that's something that this body is looking at to consolidate and maybe try to address the issues right now that are before us. So if we can get that update as soon as possible, that will be needed for our chairman of this now to look at. And I'll open up the floor now to Rep. Vice Chair.
Thank you, Chairman. Just a follow-up question. Also, the monies that were appropriate, most specifically the CGRT monies that was appropriated. Man, I wish I can give you guys the exact number. I know that there was a minimum appropriation of $10 million back in the 20th legislature on CGRT monies. CHCC didn't receive those, if we can get maybe an update from you guys and we'll consolidate from our side, then we'll work with finance to make sure that those monies from the local level and the cinema level gets to you guys from prior year.
We could share a flash drive.
I can share just if you give me a minute just to add up the totals. I have those from 2019. You're looking at FY 2019.
Yes, that's the CG public loss, right? CGRT
There
monies.
there are some from the casino license fee. Is that what you're looking for?
The taxes, the gross taxes from the casino
License.
that were appropriated to.
In 2018, there was Public Law 2061, which appropriated $170,000. Does that sound right? That was all received from that law. Yes.
All right. And anything after those?
We have a really detailed breakdown.
Sure.
that we
So
can share.
if we can get that and then we'll consolidate, just let us know what you've received and what you guys haven't. I know that CHCC haven't received a whole lot of those appropriations, so we can work from our end to make sure we push that those monies get to CHCC. We may have to amend the current statute or how the statutory appropriation just to allow CHCC to actually address the true issues right now, because you guys probably purchased some of those stuff already on your own, so we can go back and reprogram those funds directly to CHCC, but for other concerns, or maybe a little bit more flexible for CHCC's ability to move the funds.
Thank you. We'll provide that table. Thank you.
Right on. Thank you very much. Thank you, Chairman.
Any further? I understand the request for the health network program is at 9 million. Is that correct?
Yes.
And this includes, I guess, everything. The airfares. Does this also include inner island? Not including, not doesn't include inner island travels and no. What is your current cost right now with inner island? Just a rough average. Is it still what was presented in the past, around 700,000, 800,000, something like that? Okay, just so that our representative from the second senatorial sees that. I open up the floor. Chairman.
Thank you, Chairman, and good morning, Madam CEO and your team. Um, I know that the local match or the percentage with Medicaid is right now at 83 and 17% local match. So currently, right now, with our cinema state plan, what is the figure for the local match? Is it 5 million for the 17%? What? Is it 5 million?
It would be much more than 5 million. So the estimate that we have up here, just as an example of a federal match of 24 million, that would be a $5 million local match. So right now,
At
the
17%, what is the figure for the local match?
for
Right now, we are 83, 17
Yes.
local match. So what is that figure that's needed
Yeah.
to pay for that local match?
If Medicaid is to get the full 64 million funding from FMAP, the local match would be 13 million, 13.10 for Medicaid, not for CTC, for Medicaid.
13 million. Okay.
Some of that.
Okay. Thank you for that clarification. My next question is there any program within CHCC that could deal with indigent patients? I know that you guys are having hard time. There's a burden within indigent patients, but is there any program that you guys can assist this indigent clientele? Perhaps some of them could qualify with Medicaid. Is there any program within CHCC that when you provide service for this no insurance customers, and do you guys like assist them and try to make them apply Medicaid? Because it seems like under your presentation, Medicaid seems to be your bread and butter and lifeline. And if CAC would have such a program or a division that could assist this indigent clientele, apparently you guys could be getting more in Medicaid funding. Is there such a program?
Hi, good morning. Thank you for the question. Yes, this is Tiffany Crisostomo, Chief of Business Operations. Tiffany Crisostomo, Chief of Business Operations. We do have the CARA office. For those who are uninsured, our team from the CARA office offers them the Medicaid application as well as a sliding fee application. We actually also assist in gathering the documents and submitting it to Medicaid for processing.
Thank you for that response. And so my next question is, what are the plans of CACC in acquiring an MRI machine? It seems to me that most of our referrals, patients that we send to Guam are for to conduct some MRI services. So, and how much would that cost?
So we are actually seeking funds from grants from Congressman Zablon's office, as well as training some of a couple of our CRNAs who are going to be going off island to get the training to be able to conduct the pain management locally.
Thank you for that response. And my last question would be, within your billing schedules, is there any percentage within all your billing schedules that you provide services in CHCC dedicated or for utilities? And how many percent is that in all the services that you provide in CHCC?
Also, for FY 2024, we budgeted utilities at a commercial rate. So if we are at a commercial rate, our revenue would be able to pay for the the, the utility rates.
So there is such a percentage in your billing schedules that are dedicated for utilities.
Considering again, the estimation is based on actual cost. So our actual cost overall, so our services, so it does include that portion. So like, for example, the FMAP, the matching is considered in that cost.
Yeah, I think it's very important that that you guys could take a look at your billing schedules, right, and include some percentage that should be dedicated to utilities, because apparently when you provide services there, you're using also power and water, so that we can deal with this CUC issue and CACC's issue moving forward. Thank you, Mr. Chairman. I you for now.
Thank you, Rep. Sablon. Rep. Manny Castro.
Thank you, Chairman. Thank you, CEO and team, for being here today. I just wanted to let you guys know that I didn't forget about our first meeting. So I see a lot of the similar presentation, and the fact that indigent care is one of the issues that's hampering the hospital. So as promised, I'm working on the legislation to repeal Public Law 17-92. Okay, because times have changed. So when people go into the hospital and they can't pay, it puts that burden on us, the ratepayers. So I think that law should be repealed so that the true costs goes back to the individuals that are responsible for that cost. The other question, so just an update for that, and then I wanted to find out in regards to billing, is because some of our constituents still have brought up that the billing is delayed. Is there like a plan to integrate the billing system to make sure that when you're getting services upstairs, downstairs gets it in real time so that the customers can, because that is going to affect the bottom line as well.
I'll turn it over to Tiffany in a minute, but I just wanted to say that a lot of our delays really has to do with our EHR, electronic health record, and we have the good news is that we are going to get new funding from the federal government as well as CIP, I believe, to be able to get a new EHR that will address the issues of billing. And I'll turn it also over to Tiffany if she has anything to add. But we are trying, to bill everybody as soon as we can.
Chairman Ayut, thank you.
Thank you, Rep. Castro. Rep. Marisa.
Hi, good morning. Thank you, Ms. Munya and team, for coming over and being present here today. So I have several questions, and I guess for me, when looking at your request for the budget, I see a lot of expenses that really doesn't tell me much of your income. So I know that the last single audit report was done in 2017. I'm sorry? 2018. Do you have any plans of getting a single audit report done? It's now 2023.
So we have a contract for the 3 years, 19, 20, and 21,
Uh-huh.
and it's ongoing. Our audit is ongoing. We have reached out to our auditor to reconvene the audit because we had some priorities that we had to do, like revenue audits what became our priority when we were facing cash position problems, right? So we had to expedite our CMS cost report,
Mhm.
which gives us Medicare money.
Mhm.
We had to expedite our Medicaid cost adjustment to give us more money. So with adjusting and recalculating almost 4 years of Medicare cost report, we had to put our financial audit on the back burner. But those are audits too. Our doing our cost report is essentially a CMS audit of our expenditure, right? So it's a federal oversight as well. So it's
Yes.
not equivalent, but be assured that our financial operations are being audited as well. And um, um, we have contracted an external auditor to fulfill the backlogs in financial audit.
Correct, because like in any business, in order to understand your financial standings, it would be good for anybody that you're going to get a loan with, right? Or anyone that you're asking money for, especially a government, to have your audits so that we understand your financial standings, whether it be good or bad, what's depreciated in value in your inventory. We need to understand these things, and 2017 is not an up-to-date audit. So when will this be anticipated completion date for these audits to finally
Yeah,
be available to us?
So we're targeting within this year to finish the three audits that are
So the end of the fiscal year or the
At
end of the calendar year?
Calendar year.
Okay. So when that's available, can you please furnish a copy to
Yes.
this committee? Thank you.
In the meantime, we could also provide our in-house and internally prepared financial statement.
That would be great in order to understand your financial standing also. And then my next question is, how much in receivables are outstanding current? All receivables.
We'll provide later. I'm not able to open it up right now.
Do you know off the top of your head at least one vendor or Medicaid?
Maybe we don't have much, 91 million.
Okay. Any other receivables off the top of your head?
800,000 from advancing medical referral airfare.
Okay.
So 800,000 of that.
Okay. What are your plans internally to collect the receivables
Medicaid has to be paid by the local government.
and everything else?
Um,
All others besides Medicaid?
we're doing billing right now. We're trying to catch
Okay.
up with that.
All
That's
right.
what
And
we're
how many years back are your receivables?
Hold. Legally, we can only hold 2 years of receivable under
Okay.
the Healthcare Billing Act. So
Okay.
yeah, so we
about 2 years.
about
2 years?
yeah.
Okay. Thanks. My next one is we mentioned briefly about CUC, and you are in an agreement now to be paying about 500,000 a month. Am I correct? Okay, and that's currently budgeted moving forward, right? Okay. Now, what are the current? Because I need to understand. In any event, right, as a taxpayer, and now that you're asking us for money, I want to clearly understand in the event worst case scenario and you cannot make these payments and you are now get cut off from CUC, can you give me the current state of your solar panels? Are they working and operational?
They are working, but they're not giving a good return at this time because we have only done the phase one. So we are waiting for a particular grant from GM Grants Management Office for the second phase, and we are pursuing the other phases of the solar panel.
Okay, how much was initially granted to you for the solar panels?
It was
The
only,
first phase.
The first phase was about 500,000,
Okay,
and then the board approved for the additional, I believe, 800,000 to be able to complete phase one.
okay, I'm not familiar of any utility grants available under the federal government, so where are you applying these grants from?
The second one was applied by the Grants Management Office, a local Grants Management Office.
Do
central
you know
government,
where they're applying this
From
from?
DOI,
So the Insular Affairs.
Insular Affairs.
Yeah, because I don't know of any federal government that provides grants for utilities. Water, yes, but not
Yeah,
power.
it's DOI.
Okay, do you know what specific agency through
The-
DOI?
There is an energy section, right? So there's an energy division.
Right, but that's for solar. But none of that will be used for payments.
Oh, you're asking about payment?
Just I'm asking about both. So you're gonna get a solar panel phase two,
Right.
right? Okay, and how much is that? Do you know?
About $1.4 million.
Okay, and how long will that take to complete?
We're just waiting for the government to be able to award it.
All right, and then when would be the award letter be received to you? Do you know?
I'm not sure.
Okay. So my next question is, how much ARPA was provided for you by the previous administration, ARPA monies?
11 million.
And how much of that what did you receive?
We received it in full.
In full?
Yes.
Okay.
That is excluding the MRI, of course.
And that's excluding
excluding
the MRI?
Yeah.
So do you have anything available for us to see on how that 11 million was spent?
So it was used to augment financial revenue deficit for the fiscal year,
For what fiscal year?
FY 2022.
And how much was that?
The 11 million.
And you paid that in full?
Yes.
So you have no receivables left?
No, deficit.
Deficit. Okay, so before that, how much was your deficit?
That is for the fiscal year FY 22. Remember,
Okay,
with
the
the
FY
increase, with the increase of Medicaid population,
Mhm.
our costs went up. However, our 2022 cost reimbursement from Medicaid were based on 2020 costs.
Okay.
So we were getting reimbursement monthly based on 2020 cost,
Okay.
while our cost increased. So the 11 million funded the expenditure to support the Medicaid PE patients that went to the hospital. So we have yet adjusted the 2022 cost report to recover that from Medicaid. So the 11 million was used to fund the 2022 cost.
All right, so in terms of, thank you. Interim financing, do you guys apply for any loans to help augment all of your deficits? And do you have any plans?
Not at this time.
So how do you suppose you are supposed to be self-sufficient if your main bread and butter is Medicaid? What are your other plans to help augment?
So we can, continue to generate the revenue. We have backlogs, like we mentioned earlier, about 2 years. So we're going to catch up to that and be able to augment some of the services.
How are you what are your plans for that? Can you be a little bit more specific?
On getting the backlogs?
No, on interim financing or loans, are applying for loans to help augment all your deficits.
Well, we
What
also
are your
have,
plans?
we can also apply some of the federal grants,
Okay.
because some of the federal grants can be used
Mhm.
for integration of services for public health, behavioral health, and hospital.
And what are those grants and where do they come from? Does all of them come from SANSA? Can you give me a detail of what that is?
We can provide it to you.
Sure, if you can, please, that would be
Sure.
great. Okay, so my next question. In your PowerPoint, you mentioned a little bit about needing 9 million for medical referral for fiscal year 2024, correct? Okay. And previous years, your last audit claimed that you had received about 2 million. You budgeted and they appropriated you 2.9 million. Your expenditures were 17 million, with the variance of overspend of 14 million. Your last audit.
That's
This is
under,
from OPA.
that audit is from the central government. That is under the governor's office. That's not under CHEC.
I know,
Yeah,
but this is a medical referral audit,
Right,
which is
right.
why that's what I'm getting. That's what
Right,
I'm referring
correct.
to.
Yeah,
Okay.
correct.
So you're asking for 9 million.
Correct.
In 2020, in 2019, they gave you 2 million,
They gave the CNMI government 2 million.
which was used for medical referral.
Correct.
Okay, that's what I'm talking about.
Yeah.
And then you spent 17 million.
CNMI government spent 17 million.
Medical referral program spent 17 million.
The CHCC only took expenditure authority over the medical referral last
I know.
FY
January
22.
2021.
Correct.
Yeah, so when you say you, it's not the CHCC management who
I understand.
spent. So,
Thank you.
Thank you.
I understand. No, I understand. I'm just trying to get to the numbers here because I don't think 2 million's enough either, right?
Yes.
No, it's
Okay.
not.
Then that's what I was alluding to. So in Public Law 22-33, in order for us to fully understand how much to fund this new network that was established, you were supposed to provide on or before each fiscal year a report to the legislature that includes the analysis of program data, including but not limited to the expenditures and reasons for off-island services and recommendations, if any. Have you done that? When?
In February and also April.
The April request, and that is referring to the March on this public law? Is that your
That's-
answer? Okay,
I believe that's
all
yeah.
right. So in April, when you provided your letter, it was only to ask for funding, okay, of the 9.8 million, which is the same as your budget. But I don't see,
It was attached.
okay, I see. What I see here is payment reference. What I see here is the summarized financial needs for all the offices. What I see is transportation and reimbursements. I see your budget. I see a very short snapshot of your expenses for each of the offices. I'm sorry, hotels and patient requirement. But I don't see any data in regard to medical referral, the patients, what they're there for. I don't need to see the names, but what are they there for as far as off-island services? So can you please provide us, based on this letter, what the referral was for,
Mhm.
whether oncology or what have you, how many went, how long was the period, and when can we get that? Because I did call your office to ask for updates. And again, it's all going back to budgetary purposes for us to better understand how much really do you need to effectively and successfully run your
Sure,
operations.
we will provide that to you.
Okay, thank you. I yield for now. Thank you.
Thank you, Rep. Flores. Rep. Omar. You, Rep. Julie.
Thank you, Chair. Good morning, CHC management and staff and team. So this is my questions regarding the inter-island medical referral. From your earlier statement or presentation, you said that you guys, your CHC commits 700K annually for inter-island. Is that correct? Correct. Okay. And what does that include in that 700K? Lodging, including lodging, airfare,
Yeah, lodging and airfare.
only those two? Okay, so it does not include any stipend or okay. So the reason why I'm asking regarding this 700K is right now there's a lot of medical patients that are being referred here, as you know, from the First Senatorial District. And there seems to be a lack of communication and coordination between the referral, RODM referral, or the liaison office and CHC. There are many occasions when patients arrived here, and then the medical referral officers are not there because RC medical office did not relay that message ahead of time. So, was there any discussion in the past to transfer the medical referral to CHC? I guess the reason why I'm asking that, because it's been a political game, between the medical referral being under the mayor's office, and it's a disservice for those patients. So that's the reason why I'm asking.
Yeah, hi, I'm Helena Palacios. I'm the chief of clinics covering all patient services for Cyclone Tinian and Rhoda. The medical referral office, the Inter-Island, is under CHCC. It has been, but not the liaison office or those services. Yeah. So is that what you meant? Like, is there any discussion
Was
about
there
the
any
lia-
discussion
about
of
the
possibly
liaison?
transferring the medical liaison office to CHC to
No,
manage it?
no,
It's
there's
never
never
been
been.
discussed. Okay, thank you. Are you?
Thank you. Any further? Rep Angelo and then Rep Camacho.
Thank you, Chairman, and good morning, CHCC and staff. So, I'm just trying to get an understanding of the difference between an MRI and linear accelerators or a cobalt machine. Because I noticed on one of your slides, it's as far as the oncology side, we saw an extreme increase. Or so, I was just trying to basically figure out what type of machine exactly do we need to purchase in order to reduce the uh, additional expense on the ecology side.
I know that there's a proposal by the former administration to give us $10 million for that, but I don't believe we need all of that.
This is for the MRI.
MRI, correct. And
Okay,
it's,
and then
we're,
are you guys looking at purchasing? Were they looking at purchasing the entry level category? Because I see there's like different types of MRI machines that we're looking at, and it ranges from anywhere between $95,000 to $150,000 per machine. So
right. We're, we're looking about probably $500 to $1 million for the purchase of the equipment. Plus, then we need to make sure that it has the proper housing
I see.
and also the staffing that needs to be trained to be able to run it, to operate it. Yeah.
All right. Thank you for that. Just wanted to get a better understanding. So thank you, Chairman. Are you?
Thank you, Rep
You wanna-
Camacho. Just a follow up. Is the MRI off the table right now, or is it still in discussion?
In regards to the government funding it,
Yes.
we have not heard anything about it. So we are, seeking other sources, which is, like I said, mentioned earlier about Congressman Sablan's office, possible, other grants, infrastructure grants, if there's a possibility. We're trying to look at every, turning stones and seeing which one can actually fund it.
Thank you, Rep Camacho.
Thank you, Chair. Good morning, CEO Moon and your team. One question. Does the Veterans Administration contribute to the hospital any form of service or financial aid to the hospital in regards to veterans treatments?
No, but we can provide services and we can get reimbursed for the services. That's just about it, but it depends on what coverage they have also. So, some are, what's the word? Service connected, yes.
Okay, so not a whole lot, huh? All right, thank you. Are you, Chair?
Thank you. And just another clarification. I did remember in the past legislature we authorized the line of credit. Is that all paid off already with MPLT? It's complete.
By end of the year, it will be fully paid fiscal year.
This fiscal year. Okay, thank you. Rep Marisa.
Thank you, Chair. So follow up, what's the balance?
And about 300,000.
300,000, okay. So do you have plans in this budget? I guess everybody has a goal, 5-year goal, 4-year goal. In your goals for this year or the next 4 years, do you have any plans to expand your psychiatric ward unit? I mean, considering that they'll now have a mental health court, have you started collaborating or even having open discussions with the judge who will be spearheading that court? I guess to kind of marry the two, right? So that services are, or at least goals and objectives are met to help those that are going through this court system.
So, Joe wants to add. But while he's walking his way here, we do have psychiatrists. With the we've been hiring psychiatrists, and really has been really helpful. And our counselors have been really working together. We do have an MOU with them.
Okay.
We recently signed an MOU.
Good.
And then you can talk more about it.
Thank you.
Good morning, everybody. My name is Joe Kevin Villagomez. I'm the director for the Community Guidance Center. And we work closely with the treatment courts in general, drug court and a mental health court. So there's a weekly staffing of all patients that come through the mental health court with psychiatric diagnosis. The goal is not necessarily to hospitalize this patient. The goal is working closely with our staff that we treat them on an outpatient basis and try to find this meaningful quality of life while they're going through this. A lot of them are participating in our day program at the Transitional Living Center. And even the patients now, starting last week, the patients that are inpatient, we have 4 chronic mental health patients that have been in the psych unit for years. They are now partaking in outpatient programs at the Transitional Living Center. So the goal is to work more in getting them integrated in the community, but closely watching and making sure that they are properly medicated. So the psychiatrists that are very much involved. So yeah, it's more trying to get mental health services out in the community rather than to put them into a institutionalized place. Like
Right.
the psych
Okay.
units.
So I'm not sure if that's in this budget, but since you are the director and the lead in that department, how much are you proposing your need is for
Right
that
now-
specific area?
Yeah, right now, all of this funding that we're using for the Transitional Living Center are federally funded.
Okay, good.
And there's a block grant and there's several other grants. And we meet every 2 weeks with our federal partners to continue to increase that funding.
Okay.
So we're trying not to get the funding into the local accounts. If we're able to get it to the federal account, that's where we're getting all the money.
Okay.
And including the part that the local money is paying is the staffing. Some of the staffing for the Transitional Living Center, actually most of the staffing is being paid out of local funding. But we're also hiring people. We just recently hired a manager for the Transitional Living Center that is locally funded, but the programs are all federally funded.
So is there a reason why that the local, is it part of the grant that the personnel be funded locally, but the grant is, what does the grant pay for then?
Well, the program itself, but
does it include personnel?
it doesn't include personnel. Mental health services, as you're probably aware because you've been in working in this area, it always gets underfunded. Okay, we're even in the federal government side, mental health services is like the stepchild of all the different programs. So the funding is coming in more now, and we're applying for more competitive grants to get those in. But the amount, for example, the PATH grant that deals with making sure that people do not become homeless for the past 25 years has been $50,000. And it takes that act of Congress to increase that. And we ask every year, but Congress it's not a priority right now for the U.S. Congress.
Well, I don't think we have the numbers for homeless anyway, if that was the case, right?
Well, it depends on how you define it, right? There's a lot of folks that are at the addiction services program that families don't want to be involved. So they are potentially homeless. So we're working closely to make sure that we find a decent housing alternative
Okay.
with them.
So assuming, I mean, and I'm sure that you know exactly what you're doing, and I guess it's a matter of writing this beautiful narrative about and describe to them what our society really looks like, right, and the need for this type of money. So I trust that you are on top of it. So kudos to you, sir. Thank
Thank you.
you. So I guess another follow-up question. So see, and I'll direct this over to, I guess, Ms. Munoz. CHCC is a Medicaid and Medicare, obviously certified healthcare system, and they can't turn people around regardless of their status to pay. So when they come in, do you just not deny them service? They're just in there and they need help, but they can't pay. So how do you do this? This is part of your receivables also?
Yeah, I mean, obviously, we need to beef up our financial counseling with the patients, right? So we are working on that. Um, including training for our staff to be able to speak to the patient, to let them know that, somebody has to pay for the bill, right? Somebody has to pay for the services. However, there's that question of, not so much what CHEC will accept
Mhm.
for payment, but exactly what the patient can pay.
Mhm.
So how much can the patient pay?
Mhm.
And we see that in oncology. We're also looking at our sliding fee. We're listing down a lot of items that we feel that is important for primary care services. Give the patient the ability to find out exactly what is wrong with them.
Mhm.
But at the same time, treatment, which is very expensive, and this is why
Mhm.
we are encouraging everyone to look at, accessing the sliding fee, but also getting preventive care, because the hospitalization is more expensive, obviously, if you
Yes.
prefer it over, I mean, where we prefer to have you be seen by a doctor, and we can manage that.
Okay. So
Yeah.
okay, thank you so much for that, Ms. Munya. So how much in total indirect costs from all the grants? How much total indirect costs do you receive?
We could only receive 10% of our
Yes,
indirect
I'm familiar.
cost, the minimis, and our biggest grant, which is WIC grant, doesn't allow us to charge indirect cost and food cost. So at an average, we get about 150,000 in indirect costs per month.
Per grant?
No, total.
Total 150,000.
50,000.
Okay. And how many grants do you have currently available to you?
I don't have that data.
More than 10,
More
less
than
than 20?
More than 20.
More than 20? Can we get a list of all of those grants, please?
Sure.
Okay,
we
thank
can
you.
do that.
And then my last question, how much are you, I guess in terms of salary, that's also included here, Ms. Munya. And how long have you been with the corporation?
10 years too long.
10 years too long?
Yeah.
So I guess my next question, if I was to ask you about your, how much you receive as your compensation, it would be probably too little.
For a hospital, for example, just in the neighboring island of Guam, who was only managing the hospital,
Mhm.
makes more money than I do.
Okay, thank you for that. I yield.
I believe that was like 4 questions. No, I didn't understand. It was one follow up. Any further? I'm gonna recognize the last. You have any? No. Okay. Then we're gonna ask the other questions. Rep Manny, short.
Thanks, Chairman. We'll make this short. CSO Caitlin, I just wanted to find out as part of strategy. Um, right now, I know it's new that medical referral was transferred to CHC. But there's as a corporation, there's a lot of things that CHC can do that the central government can't. Um, I know that a lot of our referral patients are going to places like Hawaii and California, which are really expensive locations. Um, is there a possibility if we were to look at other locations that are more affordable, let's say like Philippines or Taiwan, and possibly CHC getting a loan to procure a facility there, like a hotel or something, a small one, and um, that way it can also generate revenue at the same time, not just for indigent care or people on medical referral, but other people in general. I know right now you have a shoestring budget and you're trying to make ends meet, but like I'm just looking forward. You have a awesome team. You have a chief strategy officer on board, which is a good thing. So is that something that is possible for CHC? And if so, what do you guys need?
I think I'll just briefly answer that and then hand it off to CEO because she's been, looking more into the off-island, situation. But I think, the strategy of reducing costs for a medical referral is twofold, right? Improving on island services, expanding on island services, right? It's a shame that we're sending so much money off island, and it's local money, right? That we're sending so much money off island. So beefing up local services is one component, and improving the data systems that we have around medical referral has been a priority for our COO and for our HNP team to make sure that we have, because it isn't just as simple as a specialty, right? It isn't just as broad as oncology, right? There's lots of different procedures that need to be done, and it gets very technical, right? So improving those data systems, breaking down to ICD codes, to diagnoses codes, to CPT codes, to procedure codes, right? Making sure that we have that data. So that's one thing. The other thing is the other component is maximizing Medicaid funding, right? And I'll hand it off to the CEO to talk about that. She's very interested in that part.
Yeah, when we took over the program, we knew that it wasn't sustainable, right? Obviously, the local funding wasn't there, and one of the things, and we've already had discussions with Medicaid, but it does require a review of the Region 9 Medicaid office to approve it. Of course, the governor okaying it, and then it goes to Region 9. But we did recommend to Medicaid that they start approving a state plan to allow foreign hospitals to be covered under their program. Right now, it does not allow it. So you will see some savings, obviously, in airfare. You will see some savings also in treatment of care. We did sign agreements, MOU agreements with some of the providers, and we're adding more with the foreign hospitals. And this one will be obviously we're not an insurance, and we want the insurance company to be able to pay for the medical care. But by having these MOUs, we can actually have, for example, pickup service, logistic service that can be accommodated. And we're working with that. But again, the key component is the Medicaid, because most of our patients that are being referred are actually Medicaid patients. So we are looking into that, hoping that the foreign hospital state plan will be approved. We are also looking at allowing patients to go anywhere in the continental United States, wherever their families are, so that they can also reduce their costs. We are talking to providers about, and also to Medicaid, about putting the Medicaid CPE for coverage of services. For example, what Medicaid is paying for hospitals in the U.S., quite expensive, of course. And if it's we've talked to some providers, and some providers are actually willing to take only the 83% and not take the 17% matching. So those are conversations that we've been having a lot with off-island providers. And we also looked at, and one of the drafts that we submitted to Medicaid was providing presumptive eligibility for 90 days for patients who are getting transferred out of CHCC, so that at least they have some type of coverage, and it will cover them, the airlines, the airfare. And last, maybe not least, but also I'm not even sure if there's last, because there are a lot of things that we were discussing with to try to make this program really sustainable, is also covering the, because some territories are covering subsistence, some territories are covering lodging and ground transportation. So those are the things that we would like Medicaid to approve and have the government approve it, federal and local, and so that we can actually have a sustainable program. Thank you.
So, yeah, because I know the state plan in American Samoa, they're allowed to send them to New Zealand, which is not part of the U.S. And um, I'm not sure. Some states are even looking into privatizing Medicaid. I know that requires more extensive services, but thank you for thinking outside of the box and trying to make this work. I think a lot of the work really needs to go up to Medicaid to form a state plan that closes a lot of these gaps. Thank you.
Can I add just one more thing? I mean, I know that their situation right now is that they don't want to, tackle these state plan amendments because of the lack of funding that they have. But I think change is necessary, and change needs to be done immediately, so that when the new fiscal year comes, we can be able to at least implement them, and so that there will be a better plan for coming. Thank you.
Thank you, CEO. Follow up.
So, follow up question to Rip Koster. Thank you, Chairman. CEO, he mentioned that they're working on an amendment to allow foreign hospitals. Okay, yeah, Senator Selena, we've been working on working with Guam on how they did theirs. They finally were accepted to allow Medicaid patients and Medicare patients to be seen in the Philippines. So they've got that contractual agreement. So we've been working with Guam and how that process went, so we can actually try to decrease the cost. But I like the fact that you guys are also including transportation and lodging into this plan. And I believe that with Medicaid, we also ask that they be more stringent in the repayment plan instead of following the federal side of 1 year, because the fiscal year within the federal government changes every year. It's not like the CNMI where it happens September or October 1st forward. And we need to be more stringent in that, so that collections can be faster from their side or our side, whatever, and we can get the payments out to the providers a lot easier. And I think if we do that, whether they can change it in their policy or we would need to do a legislation, we're ready to work with them on that, just so that we can get the monies in faster from the providers. So I know we have challenges. It's not Medicaid. I know Aetna has been pretty delayed in making their payments to CHCC. We had this issue with the Hawaii hospitals when they didn't want to accept our Aetna patients in their hospitals anymore, because Aetna International has remitted payments to Hawaii. We've been making our payments, but that international. So that's something that we also need to change on our side, so we can make it, whether it's a policy, policy within Medicaid or a statute, so that we can make sure these funds are readily available and quicker to the entities that are providing the services. No, so we're working with Senator Selena. That's why she's here today, to make sure we mention that in front of her. Thank you, Mr. Chairman.
Thank you, Rep. Vice Chair Bloss. There's two Blosses in here, so Rep Atto this time. With that, we'll take a short recess. Thank you, CEO, for being here. We just need an update Thank you, CEO, for the update. We have the requests from CHCC, but we haven't seen your submittal yet, so we haven't really looked at that carefully as to what you're asking. As soon as we get that, then we may consider at least to fund some of these items that you are requesting, and that's why we're requesting the update on all these now local delegation funds that were funded or appropriate to you with regards to the second and first and the third. So that one we have to discuss with our chairman also. Till we get that update, we can see where we're at. I know this is one of our priorities this year, since it is very important, and that there's families that are out there that we're not sure what's going to happen, and that's part of the this care. And if there's no further from the members, I'll now offer the floor back to you for the closing officially. Officially.
We need money, help. Thank you. Thank you. Really, I just thank you for the opportunity. And we'll get you all we'll go back, and I realize that if there's something that we missed, please let us know. We can Omar, representative here. He does have our contact. So if there's anything that we need to submit, we would be able to bring that to you. Okay. We'll try
Thank-
to send you what we can already. All right.
Yes. Thank you, CEO, for being here with your team. Thank you for the presentation. We do have a long, long work ahead of or hard work ahead of us. So thank you for that. And with that, if there's no further, I'll adjourn to today. Thank you. Yeah.